Hello and welcome back to another episode. Today we're going to talk about the cesarean delivery, commonly referred to as the C-section. Per Gabby's Obstetrics, cesarean delivery is defined as birth of the fetus through the uterus from an abdominal incision. I'm going to include my list of references in the show notes, but I wanted to highlight one of them, which is an excellent resource that not enough residents or students know about. That is the ACOG surgical curriculum. For some reason, if you just type that into the search bar within your ACOG account, it's hard to actually find the link. But if you Google ACOG surgical curriculum, then click surgical curriculum in obstetrics and gynecology and scroll down on that first page, you will see a list of the most common obstetric and gynecologic procedures. Click on any of them, but then click on the module tab and scroll down. You will find it all: the historical relevance of the procedure, prevalence, how to prepare for the procedure, and all of the surgical steps. This resource saved my butt in residency because I would pull it up on my phone in the OR while I was waiting for my patient to be intubated and prepped before surgery, just to quickly review all the procedural steps of whatever surgery it was that I was walking into. So the link to the ACOG surgical curriculum that I just described will be in my show notes. All right, so let's dive into the episode. Today I'm going to walk you through all of the things that need to happen before the actual incision is made for the C-section. A lot of the time as a student or as an intern, I felt like this was a period of time where I didn't really know what to do with myself. And while my seniors were very good at walking me through the actual surgical procedure, there wasn't always a lot of guidance as to what needs to happen between the moment that the patient actually walks in the door and then is ready to actually have the procedure. So for scheduled cases, the patient will be rolled or walked into the OR and asked to sit on the side of the bed with their legs dangling off the edge. Ultimately, how they are positioned is up to the anesthesiology team and depends on the type of anesthesia that's going to be administered. But most of the time, it's going to be neuraxial anesthesia through a single shot spinal or a combined spinal epidural. If they are an unscheduled C-section, or sometimes we'll call it coming off the floor, meaning they were in labor but now need a C-section, they might already have an epidural in place, in which case they would be rolled into the OR on their labor bed, and we would help them slide from their bed onto the OR table directly into the supine position. And from there, the anesthesiologist would bolus additional anesthetic through the epidural catheter at that time. So whether they were scheduled or unscheduled, at this point in time when the patient is just getting set up on the table, you'll see nursing staff and anesthesia hooking up all of the patient's IVs, their blood pressure cuff and pulse ox, and we'll usually give the patient a pillow or a Mayo stand that they can use to support themselves with. Ways that you can help during this process include offering to get the patient some warm blankets, and or just simply standing in front of the patient and holding their hand, providing reassurance, and helping them stay in the correct position while the anesthesia team does their thing. Once they are anesthetized, you can help the patient to lay down in the supine position, and then you can ask the anesthesiologist to airplane the bed to the left about 15 degrees to minimize compression of the vena cava. The next thing you want to do once they're in the supine position is to make sure that you're capturing fetal heart tones with the external monitor. A frequent physiologic response to neuraxial blockade is maternal hypotension, which can then in turn lead to fetal hypoperfusion and then non-reassuring fetal heart tones. So you want to make sure that if that happens, you actually catch it so that you can then move quickly and get that baby out faster. If this is an unscheduled C-section and they're coming from the floor, they might have an FSE in place already, which is a fetal scalp electrode, and you'll just have to determine at what point you want to take that off. Then you're going to continue helping to position the patient, so you want to ensure that both arm boards are attached to the bed and the patient's arms are placed and secured comfortably on them. You can then help position the patient's legs into a sort of butterfly or frog leg position. And at this point, you're going to do the vaginal prep if that's something that you're planning to do, and place the Foley. The vaginal prep is optional. The ACOG does not definitively recommend a vaginal prep or a vaginal cleansing, but if you read the practice bulletin that I'll link in the show notes, they do reference a meta-analysis that did demonstrate pre-op vaginal cleansing in laboring patients or those with ruptured membranes to reduce the risk of endometritis and post-op fever, just not reduce the risk of wound infection. Most of those studies that were evaluated utilized povidone iodine solutions for cleansing, although others used a chlorhexidine-based solution. Where I work, if the patient we are operating on has been laboring or their membranes have been ruptured, then we do a vaginal prep. And your institution may already have a protocol for this. Then, whether or not the vaginal prep is completed, a Foley needs to be placed, which is usually done by nursing staff. You just want to make sure that the Foley tube is placed under the leg and off tension to minimize the risk of urethral injury. And at some point throughout this preparation process, you want to communicate to your anesthesiologist what antibiotics you would like. I'll probably do a separate episode on pre-op antibiotics, but to keep it short, generally, you're going to be requesting a first-generation cephalosporin like cefazolin or brand name Ancef in the United States, with or without azithromycin, and the goal is to have that administered prior to the incision. Then, if you're going to be using monopolar electrosurgical instruments like the Bovie, you need to make sure that a grounding pad is placed on the patient, typically on their thigh. You're also going to want to make sure they have SCDs placed, which is short for sequential compression devices. These go on their lower extremities, and you want to make sure that they are in the right position. Different brands of SCDs look and function differently. I would say the type that I've seen more commonly have an inflatable portion on only one portion of the actual piece of fabric that wraps around the calf. So the inflatable portion should be on the calf, not the shin. So when it inflates, it's actually squeezing the calf. So you want to make sure it's correctly placed. You want to make sure that they're plugged into the machine, and then you want to make sure that the machine is actually turned on. I have had a few experiences where during surgical timeout, someone announced that the SCDs were on, but the machine actually hadn't been started. So just use those eyeballs to double check. Then you want to make sure the patient's legs are secured in the supine position with a strap that does not allow them to easily move their legs. Usually we'll just place a blanket over the legs and then the strap goes over the blanket, ideally over the patient's thighs, not their kneecaps and not their shins. That's not really going to prevent them from moving if suddenly they start to thrash around. Lastly, before you're ready to scrub, usually once all of the previously mentioned steps are completed, that's when the abdomen can be sterilely cleansed. You can remove the fetal monitor, wipe away any excess gel from the abdomen, and generally you'll have the assistance of OR nursing staff to help apply the surgical scrub and do all of this, but it is important for you to know how these processes work. Chlorhexidine alcohol preparations are superior to povidone iodine solutions in preventing surgical site infections. This has been well studied. As a reminder, that big orange stick with a sponge on the end that you crack like a glow stick is chlorhexidine. A common brand name in the US is ChlorPrep. And the bottle of brown liquid is the povidone iodine solution, and a common brand name in the US is betadine. So chlorhexidine needs 3 minutes to dry completely prior to draping the patient because it is alcohol-based, and if it doesn't dry, there is an increased risk of fire when using electrocautery, but betadine does not require any dry time at all. And while the prep is drying on the abdomen, that's often when you'll get a chance to go and scrub for surgery. Once you are scrubbed and sterile, it's time to drape the patient. And there are all kinds of drapes, and each of them is slightly different from the other, and it's kind of a pain to have to learn how to apply the drapes properly, but that's when you really want to rely on your scrub tech because they will know exactly how to place it. But the general idea is to cover everything but the portion of the abdomen that you're going to be operating on. Once the drape is in place, then you want to set up your suction and your Bovie. So you're going to pass the loose end of your suction tube and Bovie cord off the surgical field to someone who can plug it into the respective machines. You might also have a little plastic cup for your Bovie to sit in, and you can clip that onto your drape with an Alice or any type of clamp so it doesn't fall off the drape or into the drape. And then last but not least, you are going to test for adequate analgesia by taking a clamp, usually an Alice clamp, and you're going to pinch along the area that you plan to incise and up to the umbilicus. Let anesthesia know when you're doing this so that they can assess the patient's response and confirm whether or not you're ready to go. Then, once the anesthesia has been confirmed adequate, you can ask the OR nurse to go ahead and bring in the patient support person if they have one. The reason we don't usually invite them in before we've tested is just because if the patient does not have adequate anesthesia and they need to go under general anesthesia, the support person is typically not allowed to be present in the room for that. And that's going to be institution specific, but I would say probably most institutions are not going to allow a patient's partner to be in the OR when the patient is intubated and under GA. So there you have it. I will see you in part 2, surgical steps of the cesarean delivery.